You know, there are certain diagnoses in medicine that really keep you up at night.
Mm-hmm.
And I don't mean the super rare, the house MD stuff that you might see once in a whole career.
Right. Not the zebras.
No, not the zebras. I mean the imposters. The
Mm-hmm.
things that walk into the clinic looking like, I don't know, a stomach bug or maybe a mild flu or just
Yeah.
general malaise.
The chameleons.
The chameleons, exactly. The
Yeah.
ones that hide in plain sight. And then all of a sudden the patient just crashes.
Yeah.
And today we are pulling the curtain back on, I think, two of the biggest imposters in the human abdomen. We are talking about the liver.
And specifically, we are talking about the liver abscess. Now, I know what you're thinking when you hear that.
Yeah.
Abscess.
Yeah, it's an ugly word.
It is. It sounds like something you just, pop and put a Band-Aid on. It sounds mundane.
It sounds incredibly unsexy.
Hmm.
I mean, when I saw the topic liver abscesses, my first thought was, okay, are we really going to do a whole hour on pus? But then I started digging into the source material we pulled for this deep dive, and I realized this isn't about pus at all. This is high-stakes gambling.
It is. It's a detective story where if you guess wrong, the consequences are, well, they're catastrophic. Because here's the setup.
Okay.
You have a patient, they have a fever, they have pain in their right side. You are standing at a fork in the road.
A fork in the road.
Exactly. Down path A, you give them a pill, and they walk out, totally cured in a week. Down path B, you have to stick a tube into one of their vital organs, drain liters of fluid, maybe even operate.
Or they die.
Or they die of sepsis.
And the kicker.
The kicker is that on the surface, from the outside, path A and path B look almost identical.
That is the hook for today. That's what we're breaking down. It's the showdown. Amoebic liver abscess versus pyogenic liver abscess.
It's a classic battle in medicine, a true classic.
And looking at the research, there seems to be a golden rule that separates them. And if you understand this one rule, you have basically solved half the problem before you even walk into the patient's room.
That's right. It really comes down to a simple binary choice that every doctor, every medical student, and honestly anyone interested in how the body works really needs to understand.
And that choice is?
It is medical versus surgical.
Okay, let's headline this right at the top then. Medical versus surgical. What does that actually mean in this specific context?
It means that if you are dealing with an amoebic liver abscess, the first one, you treat it medically.
Medically, so pills?
Pills, IVs, yeah. Pharmacological intervention. You treat the bug, the little amoeba, and the body just heals itself. But, and this is the massive but, if you are dealing with a pyogenic liver abscess,
The other one,
you must drain it. You have to get physical. You have to mechanically remove the pus.
So amoebic gets the meds, pyogenic gets the drain.
Precisely. Medical versus mechanical. That's the whole game.
That seems, I don't know, almost deceptively simple, though. I mean, if it were really that easy, we wouldn't need to do a whole deep dive on it. If amoebic, give a pill. If pyogenic, stab with needle.
Right.
I'm guessing the hard part is figuring out which one is which before you make that critical decision.
That is exactly where the challenge lies, because they both present with fever.
Okay.
They both present with pain in the upper right part of the belly.
Right.
They both look on a scan like a hole in the liver.
So they're mimics.
They're mimics. And if you mix them up, if you try to drain an amoebic abscess when you don't need to, or even worse, if you try to treat a pyogenic abscess with just pills, you are leading that patient directly toward disaster.
Right. Okay. And our goal today is to help you, the listener, whether you're a student prepping for your boards or you just love a good medical mystery, to get inside what we're calling the examiner's mindset. We want to move beyond just like rote memorization. I don't want to just list symptoms for an hour. I want to understand the why.
What why is everything. It really is. If you just memorize lists of facts, you're going to get tripped up the first time a case presents a little atypically.
Sure.
But if you understand the underlying mechanism, why the abscess forms where it does, why the pus looks the way it does, the physics of the blood flow, then the answers just sort of fall into place. It becomes intuitive.
I love that. So we have a framework for today. We're going to build the clinical profile for each of these two suspects. We'll look at the young rural male for the amoebic side, and then we'll contrast that with the older complicated patient for the pyogenic side.
Good.
We'll talk about the traps, the common mistakes people fall into, and we'll wrap it all up with a sort of rapid recall formula.
It's a solid plan.
Yeah.
So where do we start?
Let's start with our first character in this drama, the amoebic abscess.
Okay.
Let's paint the picture. When we talk about the amoebic profile, who are we usually talking about? The source material is very, very specific about the demographic here.
Mm.
Let's create an avatar. Let's call him Ravi.
Okay, Ravi, I like it. So if you are reading a case file or, seeing a patient in an endemic area, your antenna should go up immediately if the patient fits Ravi's profile.
And what is that profile?
He is a young male. We are typically talking about someone aged, say, 20 to 40.
20 to 40. So prime of life, working age, not someone you expect to be critically ill.
Exactly. And crucially, Ravi is usually coming from a rural background or an area where sanitation might be, let's say, compromised.
Okay, and that's a huge clue, right? Because it
Yeah.
links back to how he got infected in the first place,
It's everything. It points directly to the mode of transmission.
which is the fecal-oral route, right?
Yeah.
Ingesting contaminated water or food.
Right. So Ravi is a young guy. Maybe he's working in agriculture, maybe just lives in an endemic region, and he comes in sick. But he's not just, under the weather. He's properly sick.
So what's he complaining of? What does he say?
The classic textbook presentation is a combination of fever and pain. But it's not just vague belly pain. It is specifically right upper quadrant pain, right up under the ribs on the right side.
Right upper quadrant. Okay, that makes perfect sense if we're talking about the liver. But here's where it starts to get really interesting for me. The source material highlights that these abscesses have a very specific preference, like a favorite neighborhood for where they set up shop inside the liver.
This is one of those beautiful anatomical details that tells a huge story. In an amoebic case like Ravi's, the abscess is almost always in the right lobe of the liver.
The right lobe.
The right lobe. And it is typically a single abscess. One big problem, right lobe.
Okay, so single and right.
Yeah.
But why? Why the right lobe? Is there something special about that side of the liver? Is it, I don't know, tastier to the amoebas?
It's not about taste. It's all about the commute. This is actually one of my favorite little bits of physics in the human body.
Okay.
It's a phenomenon called streaming, or more technically laminar flow. Laminar flow. Okay, let's unpack that. Because I tend to think of veins as just pipes where everything just sloshes together like a, strawberry milkshake.
That's how we usually picture it, right?
Yeah.
All the blood from the gut dumps into this one big pipe, the portal vein, and it all gets mixed up before it hits the liver.
Yeah.
But that's not actually what happens. The portal vein is a massive vessel. It's very short and it's very wide. And because of that, the blood flow inside it is incredibly smooth. It's laminar. It doesn't have time to get all turbulent and mix efficiently over that short distance.
So it's more like a multi-lane highway where the cars in the left lane tend to stay in the left lane and the cars on the right stay on the right.
That is the perfect analogy. Absolutely perfect. Now let's trace the traffic. The pathogen here is an amoeba called Entamoeba histolytica.
Okay.
It starts its journey in the gut. Specifically, it loves to hang out in the cecum and the ascending colon.
Which is the right side of your large intestine. The right side, precisely. Now, the blood that drains from that right side of the colon, it travels through the superior mesenteric vein.
The SNV.
The SMV, right. And when the SMV merges to form the portal vein, because of that smooth laminar flow, that stream of blood stays on the right side of the vessel. It's like it's in an express lane.
So it gets a direct, nonstop ticket specifically to the right lobe of the liver.
Exactly. The amoeba isn't choosing the right lobe. The current is just taking it there. It hops on the SMV bus, stays in the right-hand lane of the portal vein highway, and gets dropped off in the right lobe.
That is fascinating. So if you saw an amoebic abscess in the left lobe, that would actually be weird.
It'd be weird. It would be an outlier. It would imply that the amoeba somehow managed to change lanes against traffic, which is very rare.
So for Ravi, our young male patient, it's literally physics that dictates his pathology.
Yeah.
He has a single large cavity in the right lobe of his liver.
Exactly. Single N, right?
Now, we have to talk about the yuck factor for a second.
Okay.
Because every medical condition seems to have some vivid, memorable description of the fluids involved, and this one is... It's famous, the source material calls it anchovy sauce.
Anchovy sauce, or chocolate brown pus. It is the classic description. It's one of those things where if you are taking an exam and you see the words anchovy sauce, you basically stop reading the rest of the question and you answer amoebic. It's that distinctive.
But here's the twist, and I think this is where people get really confused. You just said pus, but the source material is very clear that it's not really pus. What does that mean?
This is a massive distinction, and it's one of those aha moments for really understanding this disease.
Okay, wait, back up a second. You have a patient with a high fever, a giant hole in their liver, and an organism that's actively destroying their cells. how can the fluid inside not be pus?
It all comes down to what pus actually is. True pus, like the kind you would get from a bacterial infection, say a staph infection on your skin, is a battlefield graveyard.
A graveyard.
Yeah. It is packed full of white blood cells, specifically neutrophils and dead bacteria and all this inflammatory debris. It's thick, it's creamy, and it usually smells terrible because of the bacterial metabolism.
Okay. So pus equals white blood cells fighting a bacterial war.
Exactly. But the fluid in an amoebic abscess is completely different. It is composed primarily of necrotic hepatocyte.
Hepatocytes being liver cells.
Right. The amoeba produces these powerful enzymes that literally just dissolve the liver tissue around it. It lyses the cells, it turns them into liquid.
Oh, wow.
So what you were looking at, that chocolate-colored fluid, is basically liquefied dead liver tissue mixed with some old blood. It is not a pile of white blood cells fighting a bacteria. It's a soup of digested liver.
That is a gruesome but fascinating image. So it's basically a liver smoothie.
A terrible image, but scientifically, yes. And because of that, it has two very distinct characteristics that are huge clues and also huge traps.
Okay, what are they?
First, it is odorless. True bacterial pus, as I said, usually smells terrible. This doesn't. And second, and this is the big one that trips everyone up, it is sterile.
Sterile?
Yeah.
How can it be sterile? There's an amoeba in there.
Sterile on bacterial culture. If you take a sample of that anchovy sauce and you send it to the lab and say, grow any bacteria in here, nothing will grow.
I could see how that would be a huge trap. A doctor drains some of this brown fluid, sends it to the lab report comes back and says no growth, and the doctor thinks, oh, good, no infection.
Exactly. They think, oh, it's sterile, I can relax, maybe it's something else. But they are missing the diagnosis entirely because they are looking for bacteria in a non-bacterial process. It's sterile regarding bacteria because it's an amoebic lysis.
That is a critical insight. So the lack of bacteria is actually a massive clue that it is amoebic.
Yes. If you get a report of sterile anchovy sauce from a single right lobe abscess in a young man, you have your answer. You don't need to look any further.
The culprit is Entamoeba histolytica.
That's the one.
Okay, so let's stick with our patient, Robbie. We suspect a gut parasite is causing this problem in his liver. So naturally, if I'm the doctor and I suspect a bug that lives in the gut, I'm going to ask for a stool sample, right?
Makes perfect sense.
I want to see the culprit in the poop.
And you have just walked directly into the stool trap.
The stool trap sounds ominous.
It is the most common diagnostic pitfall in this entire scenario. Logically, you are absolutely right. You would expect to find the organism, or at least its eggs, in the stool.
Right.
But the statistics tell a very different story. The source material we looked at highlights that only about 50% of patients with a full-blown amoebic liver abscess actually have intestinal symptoms or positive stool findings at the time they present.
Only 50%. So it's basically a coin flip whether you find it or not.
It's a coin flip, correct.
Why is that? I mean, where did the amoeba go? It had to come from the gut.
It did, but think about the life cycle. The amoeba exists in two forms. There's the cyst, which is the tough, dormant form that you poop out and is infectious to other people. And then there's the trophozoite. That's the active, moving, tissue-eating form. When the amoeba invades the liver, it has already left the lumen of the gut. It's burrowed into the wall and hitched a ride in the blood, so the main infection has moved on. The intestinal phase might be over, or the shedding of cysts might just be intermittent.
So if a doctor sees a negative stool test and says, well, the stool is clean, it can't be amoebic, they are.
They are dead wrong. They are walking right into the trap. Examiners absolutely love to test this because it separates the students who understand the pathophysiology from the ones who just assume logical connections that aren't actually there.
So the takeaway is, a negative stool exam does not rule out an amoebic abscess.
Absolutely not.
Okay, so if the stool test is unreliable, what do we use? We need to know for sure if it's amoebic or not. What's the real diagnostic tool? What's the gold standard?
Serology. That is your best friend here. You have to look at the blood.
What are we looking for in the blood?
Antibodies. You're looking for the body's immune response. There are specific tests, like an ELISA or an indirect hemagglutination test. The body mounts a significant and measurable immune response to this invasion.
And these tests are reliable.
They are highly sensitive and highly specific. They are the confirmatory tool. A positive serology in the right clinical context nails the diagnosis.
So ignore the poop, look at the blood.
In this specific context, when you suspect a liver abscess, yes, Serology wins every time.
Okay, let's say we've nailed the diagnosis for Ravi. We have our young guy, single right lobe abscess, the serology comes back positive, we know it's amoebic. Now we circle all the way back to that golden rule from the intro. How do we treat him?
The exam-winning, life-saving line is, treatment is primarily medical.
No scalpel, no drain.
No scalpel, no drain. You do not need to cut him open. You do not need to stick a tube in him. In fact, you actively want to avoid that.
So what do we give him? What's the magic pill?
The drug of choice is metronidazole.
Metronidazole, I've heard of that.
It's a nitramidazole antibiotic. It's been around for a long time, and it is incredibly effective against anaerobic organisms, including Entamoeba histolytica.
How does it work? What does it do to the amoeba?
It's quite clever. It diffuses into the organism, and inside the amoeba, it gets converted into a toxic form that then basically shreds the amoeba's DNA. It inhibits protein synthesis and causes the bug to self-destruct.
Wow.
It is incredibly effective. In the vast, vast majority of cases, you start the patient on metronidazole, either orally or IV, and the abscess just resolves. The body reabsorbs that necrotic fluid, the amoeba dies off, and the liver heals itself over a few weeks.
That is pretty amazing. You have a giant hole in your liver filled with dead tissue, and a pill fixes it.
It is remarkable, and it's precisely why distinguishing this from the pyogenic type is so important. You do not want to perform an invasive procedure on a patient if you don't absolutely have to.
And you said you actively want to avoid it. Why? What's the harm in draining it just to be safe?
Because you can actually make things much, much worse. Remember that anchovy sauce is sterile from a bacterial standpoint.
Right.
If you stick a needle through the skin, through the colon, and into that sterile cavity, you risk introducing bacteria from the outside. You can turn a sterile amoebic abscess into a super-infected pyogenic abscess.
So you could actually cause the very problem you were trying to rule out.
Exactly. You turn a straightforward medical problem into a surgical disaster.
Okay. However, the source material does mention some exceptions. There are a few rare times when you would drain an amoebic abscess. We should probably cover those so we don't get angry emails.
Yes, disclaimer time. There are 3 specific, well-defined scenarios where you break the no drainage rule.
Okay, what's number 1?
Number 1, impending rupture. If the abscess is absolutely huge on the scan and it's pressing right up against the liver capsule, making it bulge, if it looks like it's about to burst, you have to decompress it. You have to relieve the pressure.
That makes sense.
Number 2, no response to medical therapy. If you've given Ravi high-dose metronidazole for, say, 3 to 5 days, and he's not getting better, he's still spiking high fevers, his pain is worse, you might need to reconsider, maybe drain it to help get things under control.
Okay. And the third one?
The third one brings us back to anatomy. It's the exception that proves the rule about location. If you have a left lobe abscess.
Wait, but you said those were super rare because of the laminar flow.
They are very rare, less than 10% of cases. But if you see one, you have to be much more aggressive.
Why? What's so special about the left lobe?
Location, location, location. The left lobe of the liver sits right next to the pericardium.
The sac around the heart.
Exactly. If a right lobe abscess bursts, it'll most likely go up into the lung space or down into the belly. Bad, but usually survivable.
But the left lobe?
If a left lobe abscess bursts upwards, it goes directly into the pericardial sac. That causes something called cardiac tamponade. The pericardial sac fills with pus, it squeezes the heart.
And the heart can't fill with blood.
The heart can't fill, cardiac output plummets, and the patient can drop dead very, very quickly.
Okay, that is terrifying. So with the left lobe, you don't gamble, you drain it preventatively to protect the heart.
Exactly. The anatomical risk is just too high to wait and see.
Okay, that is a fantastic and thorough picture of our amoebic profile. We have Ravi, the young rural male. He's got the single right-sided abscess with anchovy sauce. We diagnose with serology, and we treat with metronidazole.
Perfect summary.
Now let's flip the script completely. Let's talk about the other side of this showdown, the pyogenic abscess.
This is where the demographic shifts dramatically. We are no longer looking at a healthy young man who was just unlucky. The classic pyogenic profile is the older, complicated patient.
Let's create an avatar for this one, too. Let's call her Mrs. Higgins.
Okay, Mrs. Higgins. So she is likely in her 60s, 70s, or 80s.
A completely different age group.
Completely. And she probably has comorbidities. Maybe she's diabetic. Maybe she has a history of cancer or is otherwise immunocompromised. She is not the healthy host that Ravi was.
Right. And unlike the amoebic case, where the amoeba just sort of arrives from the outside and attacks the liver directly, the source material says that for pyogenic abscesses, there's almost always an underlying source. It's a secondary problem.
This is the absolute core concept for understanding pyogenic abscesses. Pyogenic literally means pus-producing. We know it's a bacterial infection, but here's the critical thing to remember. The liver is a sterile organ. Bacteria don't just spontaneously appear there.
So they had to come from somewhere else.
They had to come from somewhere else. If you find a bacterial abscess in the liver, it means there's a fire somewhere else in the body, and the liver abscess is just the smoke.
So if you diagnose Mrs. Higgins with a pyogenic abscess, your job isn't done.
You have barely started. Your next immediate question has to be, where did this come from? It is a source hunt. You have to play detective.
Okay, so let's play detective with Mrs. Higgins. Where are these bacteria usually coming from? What's the most common source?
The single most common cause, by far, is the biliary tract, an infection in the bile ducts. We call it ascending cholangitis.
Break that down for us. Ascending means going up.
Right. Imagine the plumbing of the upper abdomen. You have the gut, which is full of bacteria. You have the bile ducts, which are tubes connecting the liver and gallbladder to the gut. Normally, bile flows down, keeping everything flushed out.
Like a one-way street.
Exactly. But let's say Mrs. Higgins has a gallstone that gets stuck in the main bile duct, or maybe a tumor or a stricture that blocks it. The flow stops.
So you get a backup. It's like a clogged drain.
It's a backed up sewer line. The bile becomes stagnant, and bacteria from the gut seize the opportunity. They climb up, they ascend the duct, infect the stagnant bile, and from there they spread directly into the liver tissue.
So Mrs. Higgins might have started with just a simple gallstone problem, and now she has a liver full of pus.
Correct. That's the most common route. But there are definitely others. We talked about the portal vein earlier with the amoeba.
The highway to the liver.
Well, it can carry bacteria, too. You can have something called portal pyemia.
Which means?
Pyemia means pus in the blood. So if you have a serious infection somewhere else in the belly, like a ruptured appendix or severe diverticulitis, that septic, bacteria-filled blood drains into the portal vein. The liver acts as the body's main filter. It tries to catch all that bacteria.
And if it catches too much, an abscess forms.
Exactly. So an untreated appendicitis in a 70-year-old can present a few weeks later not with belly pain, but as a liver abscess.
That is a scary progression. It really emphasizes your point that the liver is just the smoke. You have to find the fire.
That is the perfect analogy. If you just drain the liver abscess, but you leave the rotting appendix in place, or you leave the blocked bile duct, Mrs. Higgins is not going to get better. The source will just keep feeding the infection.
Now, visually, how does Mrs. Higgins's CT scan look different from Ravi's? We said Ravi had a single and right abscess.
Mrs. Higgins typically has multiple in both.
Multiple in both.
You often see this scattershot pattern on the scan. Multiple small abscesses, sometimes dozens of them. And because the source is usually systemic, like from the biliary tract or the bloodstream, it involves both lobes of the liver. It's not restricted to the right side like the amoeba was.
So multiple targets, spread out. A kind of starry sky of bad news on the scan.
A very good way to put it, yes. And think about the microbiology here, too. We aren't dealing with one specific parasite anymore, like we were with Ravi.
Right.
With Mrs. Higgins, we are dealing with a zoo.
A zoo.
A bacterial zoo. You'll find E. coli, Klebsiella, Proteus, Enterococcus, mixed anaerobes. It is almost always polymicrobial. A whole soup of different gut bacteria.
Because it's bacteria, it's creating true pus. The smelly, thick, inflammatory kind, not the sterile anchovy sauce we talked about before.
Exactly. This is the real deal.
So this brings us to the great management divide, the golden rule again. We established that Amoebic gets metronidazole. But for Mrs. Higgins, I have a feeling that pills alone aren't going to cut it here.
No. And I really want to explain why, because this is something that even some doctors miss. We have incredibly powerful antibiotics now, right? Why can't we just blast Mrs. Higgins with high-dose IV vancomycin and meropenem and call it a day?
Yeah, why do we have to get invasive? Why the drain?
It comes down to the hostile environment inside a bacterial abscess. We can call it the pH trap.
The pH trap. Okay, explain that.
An abscess is a fortress. The body does a pretty good job of walling it off with a thick, fibrous capsule to try and contain the infection. So first, it's physically hard for antibiotic drugs in the bloodstream to penetrate that thick wall in high enough concentrations.
Okay, so a delivery problem.
A delivery problem, exactly. But even if the drugs get inside, the environment in there is incredibly hostile to them.
Hostile how?
It's highly acidic. All that bacterial metabolism and cell death creates a very low pH environment.
And antibiotics are picky about pH.
Many of them are, yes, especially a class of drugs called aminoglycosides. They simply stop working in an acidic, low-oxygen environment. They are chemically neutralized. On top of that, the abscess is full of what we call organic debris, all this dead protein and junk. The antibiotics just bind to all the junk instead of binding to the bacteria.
Wow. So you could be giving the patient the exact right drug for the bacteria you've identified, but once it enters the abscess cavity, it's completely disarmed.
Exactly. It's like sending highly trained soldiers into a toxic swamp where their guns immediately jam. They can't fight. That is why you must drain it. You have to physically remove the pus.
You have to drain the swamp.
Literally, you drain the pus primarily to remove the massive bacterial load, but you're also doing it to change the environment. You remove the acid, you remove the debris, you restore blood flow, and you allow the antibiotics to actually get in there and work effectively.
So for pyogenic, the rule is drainage is mandatory.
Mandatory, non-negotiable. Usually the first step is percutaneous catheter drainage. A radiologist uses an ultrasound or a CT scanner to guide a needle and then a small plastic tube, a catheter, through the skin and into the abscess.
And you just leave it in.
Yeah, you leave it in to drain for several days. Sometimes if the abscesses are too numerous or the pus is as thick as toothpaste, you need formal surgery. But the principle is the same. The pus must come out.
And this is done along with antibiotics.
Oh, absolutely. It's always a combination therapy. Drainage plus broad-spectrum antibiotics to cover that whole zoo of potential bacteria. But you cannot skip the drainage. If you try to treat this with antibiotics alone, Mrs. Higgins will almost certainly not survive.
So let's recap the pyogenic scenario. You see an older diabetic patient. The scan shows multiple abscesses in both lobes. You immediately think there's an underlying source, probably biliary disease.
Yeah.
And the answer is always drainage.
You've got it. That's the algorithm.
Now, before we move on to complications, there was one other little trap mentioned in the source material. We talked about the stool trap for the amoebic side, but there's a test called the Cassoni test that apparently confuses a lot of people.
Ah, yes, the Cassoni test. This is a bit of a historical artifact that still pops up on exams specifically to trick you.
What is it? What was it for?
The Cassoni test is an old skin test that was used to diagnose hydatid disease.
Hydatid. That's the tapeworm one, isn't it? The one you can get from dogs?
Correct. The parasite Echinococcus granulosus. That disease causes liver cysts, which are different from acute abscesses. But because it's another fluid-filled thing in the liver, students often get it mixed up with amoebic testing.
So they see the name Cassoni test on a list of options and they think, oh, that sounds exotic. Maybe it's for the exotic amoeba.
Right, or they see a clear amoebic case and they wonder if they should order a Cassoni test. The answer is an emphatic no. Cassoni is for hydatid. And frankly, we barely even use it for that anymore. We use serology for hydatid disease too.
So for the purpose of this deep dive, the advice is,
do not let hydatid disease or the Cassoni test distract you from the core amoebic versus pyogenic binary. It's a classic red herring.
got it. Cassoni equals hydatid. Ignored for today's discussion.
Exactly. Keep your eye on the ball. Medical versus surgical.
Okay, let's talk about when things go really wrong. Section 5, complications. We touched on this briefly with the pericardium and the left lobe, but the source material goes into a lot more detail about rupture risks.
This is very high-yield territory, both for exams and for real life. Because if an abscess ruptures, the patient's clinical picture changes completely, almost instantly. And it's all about physics and direction.
Okay, walk us through the physics of the rupture. Let's visualize the liver again. It's this huge organ tucked right up under the diaphragm on the right side of the body.
Right, so imagine a balloon, a water balloon, expanding inside the liver. It's getting bigger and bigger, and the wall is getting thinner and wants to pop. The direction it pops in determines the symptoms. Let's start with the most common direction of rupture, up. Up towards the chest and the lungs.
Exactly. If a right lobe abscess, which is the most common kind, bursts upward, it erodes right through the diaphragm muscle and bursts into the pleural cavity.
The space around the lungs.
Right. So now all of a sudden Robbie or Mrs. Higgins presents with a cough, shortness of breath, and chest pain. And on a chest x-ray, you see a right-sided pleural effusion. They have fluid in their chest.
This sounds like another massive trap. If I'm a lung doctor, an intensivist, I might see that fluid in the chest and think, oh, it's pneumonia, or it's a lung abscess.
Exactly. You're chasing a lung problem, but the villain is actually in the liver. You might even put a chest tube in to drain the pus, but it just keeps refilling because the source is below the diaphragm. You have to learn to think, why is there pus in the right chest? I have to check the liver.
That is a critical connection. What about down if it ruptures downwards?
Rupture into the peritoneum, that's the main belly cavity. This leads to generalized peritonitis. The pus just spills into the entire abdomen.
And the patient's presentation. Oh, it's dramatic. The patient's belly becomes rigid, board-like, and incredibly painful. It's a full-blown surgical emergency. They look just like someone with a perforated ulcer or burst appendix.
And the third direction, which we already mentioned, is the most lethal one. Rupture into the pericardium.
The heart sac. And again, this is almost exclusively a risk with a left lobe abscess because the left lobe sits centrally, right under the heart. If it bursts up, it fills that pericardial sac with pus.
Cardiac tamponade.
The heart, as we said, is encased in this tough, non-stretchy bag. If you fill that bag with fluid, the heart gets crushed. It can't fill with blood between beats.
And the outcome?
Blood pressure plummets. The neck veins distend. It is a rapid spiral to death unless you intervene immediately with a needle to drain the sac.
So, anticipating where the fluid might go helps you catch these complications early. If you have a patient with a known liver abscess who suddenly gets short of breath, your first thought is pleural rupture.
Exactly. Or if they suddenly collapse with low blood pressure and muffled heart sounds, you have to think pericardial tamponade. It's about anticipating the disaster before it fully unfolds.
It really validates the old idea that in medicine, anatomy is destiny.
It always comes back to anatomy, always.
This brings us to the ultimate synthesis. We have covered a lot of ground here. We have our two characters, Ravi, the young rural male with his anchovy sauce, and Mrs. Higgins, the elderly diabetic with her multiple abscesses.
And now we need to bring it all together. The source material suggests a great way to do this is with a visualization, a mental comparison table.
Well, let's build that table verbally for the listener right now. I want everyone listening to picture this. 2 columns in your mind. Column A, amoebic. Column B, pyogenic.
Okay, let's fill in column A, amoebic.
Patient profile.
Young male, 20 to 40 years old.
The history.
Rural background from an endemic area.
Okay. The abscess itself.
Single, large, and in the right lobe.
And the pus.
And the pus. Chocolate brown, and, crucially, sterile and odorless.
Diagnostic.
Serology positive. Remember, the stool is unreliable.
And finally, treatment.
Medical, metronidazole, no drain.
Simple. Clean. I've got that picture in my head. Now let's do column B.
Okay, column B, pyogenic. Patient.
Older, complicated.
Yeah.
A patient like Mrs. Higgins, maybe diabetic.
History.
Often a history of biliary disease, like gallstones, or a recent intra-abdominal infection.
The abscess.
Multiple, often small, and involves both lobes of the liver.
And the pus.
This is true bacterial pus. Thick, smelly, and it will grow a zoo of bacteria on culture.
Diagnosis.
You do the culture, but the most important part is the source hunt, finding out where it came from.
And the big one, treatment.
Drainage is mandatory, plus broad-spectrum antibiotics. It really is a stark contrast when you lay it out side by side like that. It's almost like they are perfect mirror images of each other.
They are, and that's why the rapid recall formula from the source material is so powerful. It just boils it all down to a simple equation you can hold in your head.
Give us the equations.
Equation 1 for amoebic. Young patient plus single abscess plus anchovy sauce plus metronidazole, amoebic.
Got it. Young single anchovy metronidazole.
Equation 2 for pyogenic.
Huh.
Old patient plus multiple abscesses plus an underlying source plus drainage, pyogenic.
Old multiple source drainage.
That's it.
That is brilliant. It just cuts through all the noise and the details.
The source material claims this algorithm solves most exam questions on the topic in under 10 seconds. And honestly, in my clinical experience, that's true. If you spot the pattern, you don't need to agonize over the details. You know which path you're on.
And that leads us to the philosophy of all this. Why does this deep dive really matter? I mean, sure, it helps you pass an exam, but there's something bigger here, isn't there?
I think so. I think it's about pattern recognition. Medicine, at its core, is overwhelming. There's just too much data, too many facts. You can't possibly memorize every single thing.
No way.
The best clinicians, the ones you want treating you or your family, are the ones who have learned to recognize the key patterns amidst all that chaos.
It's about identifying the signal in the noise.
Exactly. And in hepatobiliary surgery or in emergency medicine, distinguishing these two conditions is arguably the highest yield pattern recognition skill you can have, because the cost of getting it wrong is so high.
Right. If you cut when you should medicate, if you put a drain in Ravi unnecessarily, You can cause real harm.
And if you medicate when you should cut, if you just give pills to Mrs. Higgins and send her on her way, she dies. It's that simple.
It's a very sobering thought. The decision is binary, but the stakes are, for the patient, infinite.
That's the burden of the profession, but it's also the beauty of it. When you get it right, when you see the pattern and you see Ravi walk out of the hospital a week later just because you knew to check the serology and give him a simple pill, that's a good feeling.
So let's leave the listener with a final provocative thought. Something to mull over.
I want the listener to really think about this binary medical versus surgical, not just for the liver, but as a fundamental framework for how we approach disease. But specifically for this topic, my thought is this. Mastering this one distinction permanently eliminates confusion. If you know the pattern, you cannot be tricked.
You can't be tricked. I like that.
The next time you see a case or a study question, or even hear about a friend or relative with a liver issue, I want you to immediately ask that question in your head. Medical or surgical? Look at the age, look at the history, look at the number of abscesses, and bam, the path forward becomes clear.
Medical or surgical?
Yeah.
Young or old? One or many? It's a simple set of keys that unlocks a very, very complex door.
Couldn't have said it better myself.
Well, that is all the time we have for this deep dive. We hope you feel a little more like a liver detective than you did an hour ago.
And remember, if it looks like anchovy sauce, put down the scalpel.
Always watch out for the anchovy sauce. Thanks for listening, everyone. We'll catch you on the next deep dive.
Yeah, bye.
See ya.